Good afternoon, everyone. Thank you for joining today's webinar, Impact of COVID-19 on Global Elimination of Viral Hepatitis, the U.S. Perspective. I'm Dr. John Ward. I'm Director of the Coalition for Global Hepatitis Elimination of the Task Force for Global Health, and I'm pleased to be moderating today's webinar. Today's webinar is being recorded and will be made available on the AASLD website and in Liver Learning. This webinar is being brought to you by AASLD and its 6,700 members. Our members are instrumental in creating exceptional educational content, such as this webinar tonight, and I invite you to join us in future educational opportunities, including the upcoming liver meeting. You can play a vital role in bringing liver disease and treatment to the forefront and take advantage of the many member benefits offered by AASLD. Please visit aasld.org to learn more about becoming a member. We'll be looking at various aspects of the impact of COVID-19 on viral hepatitis prevention, care, and treatment. I'm going to get the slides advancing here in just a moment. And here's the webinar agenda for this evening. I'll be giving a few opening remarks and particularly giving you some information regarding the impact on hepatitis prevention, testing, and treatment coming from a variety of sources to really provide some complementary information from what you'll be hearing from Dave Thomas, who will be describing the relationship between SARS-CoV-2 infection and chronic liver disease. Then we'll be hearing from Dr. C Des Jarlais about the impact of SARS-CoV-2 and COVID-19 response on access to harm reduction services needed to reduce transmission of HCV among people who inject drugs. And then we'll be hearing from Dr. Natasha Martin from some modeling data to look at the impact from the interruption of hepatitis prevention, testing, and treatment services. Next slide, please. This is just a reminder to please submit your questions in the Q&A section that you can see the icon at the bottom of your screen, and we'll be having a ample time for discussion at the end of the prepared presentations. So please bring your questions forward so we can have those as part of the discussion. Thank you. This is Dr. Thomas. Next slide. Dr. Des Jarlais and Dr. Martin. And these are the representatives of the committee that helps prepare this webinar series. Give you next slide, please. Just want to give you some information from some sources, as I mentioned, regarding this impact, and it has been a considerable impact but a necessary one if you think that this is really a global health emergency, and really all available resources had to be brought to bear in most countries to respond to this new health threat. Next slide, please. So I really wanted to touch base on the impact on some of the key interventions needed to achieve our elimination goals as they are listed here, and you'll be hearing more about these as we go through our program. Next slide, please. First of all, hepatitis B vaccination for children beginning immediately after birth is really the cornerstone of hepatitis B elimination, really providing lifelong protection from hepatitis B. Unfortunately, during the response to COVID-19, there has been large declines in hepatitis and really vaccine coverage, including hepatitis B vaccine for children. as was shown in the graph, as is shown in the graph on your right from a MMWR article looking at the state of Michigan, there has been large declines in the all vaccine coverage of young children, really throughout the country. As you can see, those proportions falling below 50% from upwards of about 70% typically. And this is because of people being hesitant to bring in their children for well baby or well child visits. That has explained some of those. More broadly, look at globally, most other countries are reporting large interruptions of services as well. And WHO estimates that as over 5 million new hepatitis B infections may be resulting from these interruptions, resulting in 1 million future HBV deaths if these interruptions are sustained. So it's very disturbing. We need to keep in mind that vaccine is an essential health service, and we need to do all we can to remain to get these coverage levels back up to their pre-COVID levels. Next slide. We've also been doing a survey that AASLD has been a part of to help providers tell us what has changed in their practice during the COVID-19 response. That survey is still open. The link is as listed here. Really encourage you to be part of this if you're a hepatitis care provider. Next slide, please. We've gotten today about 69 responses from 32 countries that are listed on your right. I really didn't pull out the U.S. because the impact is really fairly universal. There are not large differences if you look at this by regional level. Next slide, please. First of all, most providers are reporting doing something different to improve infection control in their practice, as you can see here, particularly including asking patients to wear masks, among others. Next slide. They are reporting large declines in hepatitis B screening. As you can see there, almost 50% are reporting a decline of 26% or more in hepatitis screening, and even larger proportional declines in hepatitis C treatment. And similar declines are seen for hepatitis B. Next slide, please. They're also reporting changes in their routine care to improve social distancing and reducing contact of patients to the healthcare system, with deferring testing, imaging, and increasing pill counts so people do not have to return for refills. Next slide, please. They're also reporting more use of telemedicine, with the lighter color bar representing what was going on in the month where the COVID response was greatest. And then we also ask about the most recent month, suggesting that there has been a trend toward less telemedicine, perhaps reflecting at that point in time of the survey being taken, the COVID cases may be declining and more of a return to routine patient services. We'll just have to see how this trend continues as more persons take this survey. Next slide, please. Only a subset of these providers surveyed to date were opioid substitution therapy providers, but of those that were, they were also reporting interruptions in that. And we'll be hearing a little bit more about harm reduction access from Dr. Des Jarlais. Next slide, please. Providers also were reporting there are some positive outcomes from the COVID-19 response. In particular, better testing capacity from these 32 countries, better reporting of results, improvement in surveillance, contact tracing, better training of clinicians to take care of people with infectious diseases. So it'll be very interesting to see how we can marshal these improvements in the healthcare system toward hepatitis testing and treatment, particularly as cases of COVID-19 wane. So we really look forward to seeing how we can seize those opportunities to help our patients at risk for or living with hepatitis B or hepatitis C. Next slide, please. Hopefully that gives you a little bit more context of some of the challenges that we're facing in providing care and prevention services for hepatitis. Now let's turn to Dave, where he'll give us an update of the medical impact of COVID-19 on persons living with liver disease. Dave?
Thanks a lot, John, and thanks to you and Nancy for organizing this, and to the Society for continuing to keep hepatitis C elimination in the forefront of our mind as we deal with this pandemic. I'm delighted to share with you just briefly a bit about how COVID actually affects the liver, how it manifests the expressions of disease, and how it might impact patients who have pre-existing hepatitis or other forms of liver disease. Next slide, please. These are my disclosures, which do not materially affect my presentation. Next slide. So, the hallmark of hepatitis is transaminitis. And so it was very quickly appreciated that patients with COVID-19, even in the very first outbreaks described from China, had a substantial proportion of them have elevated transaminase levels, raising the question of really what was going on. Was that underlying hepatitis, or was that SARS itself, or was it just the effects on the lung? So I'll start out reviewing those data. Then I'll consider the specific instance of how SARS-CoV-2 can affect patients with the most severe liver failure, and specifically those with decompensated cirrhosis. And then I'll deal with the special challenge at the far extreme of those with liver transplantation. And then finally consider how that might affect management, and a bit about the, very briefly on the pathophysiology. So next slide, please. So these are one of many studies that describes the incidence of liver enzyme elevations in persons presenting to hospitals. So this is a subset of hospitalized patients with SARS-CoV-2 infection. And so you can see that these data are stratified according to whether the SARS-CoV-2 was severe, requiring substantial oxygenation or intubation, or non-severe, but yet nonetheless requiring hospitalization. And as you can see, the median AST levels, median ALT levels, median ALK Phos, and total bilies are actually not substantially elevated. They're higher in those with severe compared to non-severe COVID, but at least at the median level, these are not markedly elevated, maybe 1.5 times what would be expected. But you can also see quickly that there's quite a wide range, and tenfold elevations of liver enzymes were also not uncommonly observed. Next slide, please. Now, I like this study because it also took advantage of the fact that some of these patients had antecedent liver enzyme studies. And so you could look back, for example, at the AST in this slide. Notice that in the kind of orange looking bars, you can see pre-admission, and then in the green, the admission AST levels. And notice that they're certainly higher with COVID, but not markedly higher, and they're stratified again according to disease severity. So in some with more severe COVID, liver enzymes are higher, and liver enzymes are higher overall in persons with COVID compared to those without, or in the same person. It's really the best control before COVID. Next slide, please. In addition, it's possible that this study that came out of Dr. Verna's group is really helpful in the sense that it compares persons admitted who are similar in many respects to the COVID patients who don't have COVID, so that we can get an idea of what happens to other hospitalized patients without COVID. And you can see that there is a trend towards more hepatitis, more higher liver elevations in persons with COVID compared to these hospitalized controls. Next slide, please. And then in their study, they tried to understand why would that be? Why do the persons with COVID have elevated liver enzymes? And modeled the five-fold elevations in this particular data that I'm showing. And you can see that they correlated nicely with the what we describe as this cytokine storm syndrome, where there's a surge of IL-6 and ferritin and CRP and other measures of showing immune activation and unchecked and dysregulated immune responses, all correlating with these liver enzyme elevations. Next slide, please. Now, although the outcomes are just modestly, the liver enzymes are only modestly elevated overall in persons with hepatitis and in particular in persons with COVID. If you look at individuals who have cirrhosis, you can see this dose-response relationship that was described at EASL recently, and these data are impressed from a multi-center registry of 1,365 patients, 745 of whom had chronic liver disease, and 386 with cirrhosis, and then 620 without liver disease. And you can see that in the first figure there, that if we just first of all focus on mortality, the outcome of the SARS-CoV-2 infection, you can see that it's highest in persons with Child-Pugh C in the dark red, and then B in the orange, Child's A or compensated cirrhosis in the lighter orange, and then in the yellow, persons with chronic liver disease whose mortality is really considered what you might expect in average patients, if you will. And then if you kind of take the odds of dying in the middle figure and compare those persons with cirrhosis at various stages of cirrhosis, once again, this dose-response relationship with higher mortality in persons with Child C compared to B, B compared to A, and A compared to persons with chronic liver disease whose mortality was not appreciably increased. And then finally, that last figure that describes sort of what you might consider to be the attributable difference, or how much higher the mortality would be by these. And once again, the same message. So what we know for sure is that if you are a patient with decompensated cirrhosis, getting SARS-CoV-2 infection can be really very problematic, with a very high rate of mortality. And even in patients with Child's B, the risk of mortality is considerable. In contrast, it doesn't appear that there's a measurable increased risk in a person with very well compensated chronic hepatitis or other forms of liver disease that are not yet cirrhotic. Next slide, please. Now, this special group of patients with, there are some data on our transplant patients, and not surprisingly, sort of common sense would tell you that it would certainly be better if persons on immunosuppressive drugs were not to get SARS-CoV-2. And this one published experience coming out in hepatology underscores that point, where a fifth of the liver transplant patients with COVID-19 died, and 3/4 were hospitalized, much higher than would be expected by chance. Next slide. In addition to the way that SARS-CoV-2 infections can manifest in persons with underlying hepatitis or liver disease, it's also important to consider how it might change the management of the SARS-CoV-2 itself. And I'll point you to consensus statements that Orrin Fix and others, some of the leaders from AASLD, have already very rapidly responded to this crisis with information that's available on the AASLD website. EASL likewise has guidance. And notably from the guidance is the important point that management should be, that patients with liver disease should not be restricted from potentially life-saving treatments such as remdesivir and or dexamethasone, but should be treated as per the standard of care. Next slide, please. Now, finally, what we've learned so far does bring up the question of really what's the pathogenesis and what is going on in the livers of these individuals. There have been some autopsy studies that have described SARS-like particles, coronavirus-like spikes visualized within liver and persons at autopsy. But in addition, some other studies have described, I think, indirect evidence that SARS infects the liver. But there's not a lot. The receptor, the ACE2 receptor, is expressed at very low levels in hepatocytes, tire, and cholangiocytes. So it's possible that Kupffer cells and other cells involved in the liver besides the hepatocytes could be involved. But more likely, it's kind of this, the liver is a central organ governing responses. I mean, the IL-6 converges on liver to signal for CRP production, for example. And so that whole axis is liver-centered, and therefore it's not surprising that the liver would play a role, that there might even be some bystander issues with the cytokine responses to the principally lung and perhaps gut SARS infection that changes the physiology of the liver, which can be fatal in persons with really severe portal hypertension before the SARS infection. And in addition, obviously, the liver is a central figure in the coagulation cascade, and that's been implicated with the pathogenesis of SARS-CoV-2 infection. So all that to say is we don't really know for sure how it's working, but next slide, we are sure that with SARS-CoV-2 infections, many patients will have liver enzyme elevations, that the severity of those elevations will be somewhat related to the likelihood of surviving that infection, that they'll be worse in persons with pre-existing cirrhosis, especially those with decompensated cirrhosis. And obviously our patients who are decompensated or have cirrhosis and those who've had liver transplants should be especially careful to avoid exposures to SARS-CoV-2. There are possible management implications, which I suggest you consult with your local hepatologist to sort out. And that's the end of my presentation. Thanks a lot.
Thank you, Dave. We'll now move on to Don Des Jarlais. We'll be talking about syringe service programs and HIV and HCV prevention in the United States during the response to COVID-19. Don?
Okay. Thank you, John, and I'd like to thank the organizers for inviting me to this webinar, and note my co-authors, Sarah Glick, Annalie Uskala, and Jonathan Fielmeyer. Okay. Next slide, please. We have no conflicts of interest to report. Next slide, please. For some historical background, I want to briefly go over the history of HIV among people who inject drugs in New York City. The virus got into the city and into the injecting population in the late 1970s. It spread incredibly rapidly, with prevalence reaching almost 60% within 5-6 years. It then stayed high above 50% for almost 10 years. Then in 1992, the city started its syringe exchange programs, and we saw a fairly rapid decline in prevalence. With the implementation of the syringe exchange programs, incidence went from 4 per 100 person years down to 1 per 100 person years at risk. In the 2000s, we saw a slight increase as ART was made available and people quit dying as rapidly. During that time, incidence, however, continued to decline. Next slide, please. The combined prevention, including needle syringe programs, medically assisted treatment, and antiviral therapy, can significantly reduce HIV prevalence and new infections among people who inject drugs. Several locations have documented reductions in HIV incidence among PWID as a result of combined prevention, including sites in Canada, Australia, Western Europe, and in New York City. Next slide, please. In fact, in the current situation in New York, HIV prevalence is 7% among people who inject. HIV incidence is 0.04 per 100 person years at risk. This is among the lowest HIV incidence ever recorded. However, HCV prevalence has remained stable at about 70%. This is down from the 90% HCV prevalence prior to syringe exchange, but is still distressingly high. In terms of HCV incidence, about 50% of people who inject become HCV positive by 5 years of injecting. So we're still seeing disturbingly high rates of HCV incidence when people start to inject. Next slide, please. While combined prevention and care has led to dramatic reductions in HIV, we have seen outbreaks of HIV among people who inject. Scott County in the US is probably the most famous or notorious outbreak in the US, although there are about now up to about 12. There were also outbreaks in Athens, Dublin, Luxembourg, Glasgow, Saskatchewan, Canada, and Tel Aviv, Israel. These were outbreaks before COVID. The precipitating factors for these outbreaks were community economic problems, reduction in HIV prevention services, new drugs injected in the local situation, and homeless people who inject as a highly vulnerable subgroup. In many of these outbreaks of HIV, there were outbreaks of HCV that served as a warning of potential outbreaks of HIV. Next slide, please. In terms of SARS, CoV-2, COVID-19, we're seeing community economic stress, reduction in HIV and HCV prevention services, disruption of drug markets with new drugs, especially novel psychoactive substances being introduced into the local drug distribution. And we've seen increased homelessness among people who inject drugs. Next slide, please. So basically, the COVID pandemic is replicating the community conditions for outbreaks of HIV. So, in addition, many people who inject do have the underlying conditions for severe COVID disease. So the pandemic of COVID is both greatly increasing the likelihood of HIV outbreaks and is in itself a lethal threat for many people who inject drugs. We have reports now of several outbreaks of HIV during the COVID epidemic. Next slide, please. In terms of US syringe service programs, we have somewhere between 300 and 400. That number is a little difficult to pin down because a number of programs have closed as a result of the COVID pandemic. Prior to the pandemic, HIV and HCV testing was a standard service, and people who were tested positive were referred to evaluation and treatment. We have a number of studies now of what's happened during the pandemic. We found that almost all syringe service programs ceased HIV and HCV testing during the pandemic because of the requirements of social distancing and the requirement to try to spend limited interaction time between staff and the program participants. We're seeing a little bit of attempts to restore testing, but we still basically are in a situation where HIV and HCV testing are very, very scarce in syringe service programs. Next slide, please. We do have one study from Europe of oral fluid HCV testing, which is obviously much easier to do than either the finger stick or serum collection. It can be done self-administered at a program or at home. The oral fluid test is approved in Europe, but not in the US. In a recent study in Estonia, compared the oral fluid testing to standard ELISA and found a sensitivity of 100%, but specificity of only 56%. Next slide, please. Okay. To summarize, the SARS-CoV-2 pandemic is replicating the conditions that facilitate HIV outbreaks among people who inject drugs. We need to develop methods to detect and limit HCV and HIV outbreaks among people who inject drugs during the COVID pandemic. We're basically flying blind with greatly reduced HIV and HCV testing in the community. However, there is a possibility of trying to use HCV testing to detect potential HCV outbreaks that might be followed by HIV outbreaks. Okay, thank you.
Thank you, Don. Nice job. We'll move on to Natasha Martin, who will be giving us some data from models looking at the current impact and potential impact of the COVID-19 response on HCV elimination. Natasha?
Great, thanks, John. Good afternoon, everybody. Next slide, please. These are my disclosures unrelated to this work. So, as everybody knows, in 2016, the World Health Organization Global Sector Strategy for Viral Hepatitis Elimination was issued, aiming to reduce the incidence and mortality related to hepatitis C and B by 2030. In response to that, numerous global and local settings have developed hepatitis elimination plans. And on this slide, I'm showing you the hepatitis C elimination projects in the United States as of March this year, with the yellow showing hepatitis C elimination projects and the light blue states showing areas with elimination projects for both hepatitis C and B. The rapid proliferation of projects is encouraging, particularly in areas hard hit by both hepatitis C virus and the opioid epidemic, such as in the Appalachian region. Next slide. Despite the hugely encouraging progress, many areas remain without hepatitis C elimination plans. So the left-hand side on this slide again shows the hepatitis C elimination projects in the US, and the right-hand side of this slide shows the rate of hepatitis C virus per 100,000 population, highlighting key gaps in elimination plans for areas with moderate to high burden of infection, such as the Mountain and Pacific Northwest area, Southwest, Deep South, and actually also up in the Rust Belt area. So we definitely still have gaps in terms of programming for hepatitis C elimination in the United States. Next slide. So in 2019, Louisiana launched a hepatitis C elimination plan with the aim to diagnose 90% and treat 80% of Louisiana residents living with hepatitis C virus by 2024. The ambitious plan will provide unrestricted access to hepatitis C treatment in the community as well as correctional settings, combined with expansion of harm reduction. So this slide shows the number of people who started hepatitis C treatment by month in Louisiana. And you can see that there was a dramatic increase in treatment initiations midway through 2019 when their elimination plan was initiated, from about 100 per month to kind of 500 to 600 people starting treatment after that initiation. But what you can see here on the right-hand side in the red box is that there was an immediate decline seen subsequent to the COVID stay-at-home orders in March 2020, dropping back down to about 100 treatments in April 2020. This, combined with other information that you've already heard in terms of reductions in hepatitis C testing and treatment nationally during the COVID pandemic, could stall progress towards elimination. Next slide. So to estimate the potential impact of delays in hepatitis C testing and treatment on global elimination progress, a theoretical modeling study was performed by the Center for Disease Analysis. So this study projected the impact of a 1-year cessation of hepatitis C testing and treatment in 110 countries worldwide. So they compared this impact of basically a 1-year delay in any testing and treatment to a scenario where testing and treatment were continued as before. And they found that over the course of 2020 to 2030, this 1-year halt in testing and treatment could result in over 900,000 fewer hepatitis C diagnoses globally and nearly 750,000 fewer hepatitis C treatment starts. Additionally, no global region was estimated to achieve the WHO's service coverage targets of 90% diagnosed and 80% treated by 2030 with this delay. The delay in programming could also hamper reductions in incident hepatitis C as well as liver-related mortality, two really key metrics for the global sector strategy for elimination. So the modeling study indicated that globally there could be over 120,000 more incident infections between 2020 and 2030, and 72,000 more liver-related deaths compared to a scenario with no interruption in programming. Again, in this model, no global region was able to achieve the elimination target of reducing incident infections by 90%. And only high-income countries were able to achieve the target of reducing liver-related mortality by 65% by 2030. Overall, this interruption could lead to over 600,000 more chronic infections globally in 2030 compared to without a delay. Next slide. The same modeling analyses also highlighted the disproportionate impact that a 1-year interruption in hepatitis C programming could have on liver-related mortality in areas such as the United States. Also having a disproportionate impact in countries such as Australia, Brazil, and regions like Western Europe. Here you can see the United States could see as much as a 20% relative increase in cumulative liver-related mortality over the next 10 years between 2020 and 2030 because of this 1-year simulated disruption. Next slide. So compounding these negative effects of interruptions to hepatitis C diagnosis and treatment programs, disruptions in harm reduction access could additionally hamper progress towards reductions in hepatitis C incidence. So in 2019, Mexico launched a plan to eliminate hepatitis C, but high prevalence and incidence of hepatitis C among people who inject drugs means that a combination harm reduction and treatment strategy is likely required to reduce incidence by 80% by 2030. So here I'm showing a simulation study that we did looking at what is required to reduce hepatitis C incidence among people who inject drugs in Tijuana, Mexico, which lies on the US-Mexico border region right adjacent to San Diego. We show that the hepatitis C elimination target could be met with a combination scale-up of hepatitis C treatment and harm reduction. But what this slide is also emphasizing is the potential negative impact of disruption of harm reduction programs. So unfortunately, interruptions to harm reduction programs are common in Mexico, particularly since the reclassification of Mexico as an upper middle income country and the withdrawal of the Global Fund support for syringe service programs. So our modeling study showed here that even in the background of progress towards elimination, an interruption of harm reduction services, even of just 1 year, could reverse this trajectory, which is shown in the black square. So it could, whereas incidence is decreasing with combination prevention, just a single year of disruption in harm reduction could reverse that trend and actually lead to a subsequent increase in incidence just in 1 year. Really, I think highlighting the critical importance that even short-term disruptions in harm reduction availability can have on incidence elimination targets. Next slide. Further, as you've already heard today by Dr. Des Jarlais, there's emerging evidence that the overlapping syndemics of opioid misuse, hepatitis C, HIV, and overdose have continued, and perhaps have even been exacerbated by the COVID pandemic. The left-hand figure shows reported suspected overdoses, both fatal and non-fatal, which are reported to this overdose mapping system in the United States, with the pre-COVID era in the bars in red and the COVID era in the bars in yellow, shown from March until May of this year. So this analysis shows that there has been a sort of continued increasing reports of overdose, but also their analysis shows that there have been more reported overdoses in the COVID era than would have been predicted based on past trajectories, indicating that the COVID era may have exacerbated this overdose risk. The right-hand side of this slide shows provisional drug overdose deaths as reported by the CDC, indicating that in the January to March period of 2020, as circled in the red, there was a steep rise in overdose deaths. And of course, we'll be monitoring this closely as we move forward and accumulate more information in terms of how this is playing out in the COVID era. But I think overall, these data really further underscore the critical importance of sustaining and expanding harm reduction programs in this period where social distancing and economic hardship may further compound feelings of isolation and despair, fueling opioid misuse and contributing to hepatitis C, HIV, and overdose in the United States. Next slide. So in summary, key challenges to hepatitis C elimination in the COVID era include reductions in hepatitis C testing and treatment and potential disruptions in harm reduction interventions, such as syringe service programs. Really critically, there remain continued gaps in surveillance for hepatitis C that hamper our ability to monitor our progress towards elimination in the United States, as well as anticipated budget constraints due to the COVID era, which threaten our ability to facilitate hepatitis C elimination programs. Finally, the ongoing syndemics of opioid misuse, overdose, and viral hepatitis and HIV remain a concern and may be worsening in the COVID era. Next slide. However, as already mentioned today, there are many potential opportunities. Innovation and decentralization of hepatitis C treatment and prevention services could meet people where they are and provide new and effective models of care, including, as you've heard today, telemedicine, mobile outreach of hepatitis C testing and treatment combined with harm reduction, and home testing opportunities. Also, integration of viral hepatitis and COVID services is possible and can provide a new avenue for diagnosis and linkage to care. There may also be a potential for improved testing and clinical training from COVID capacity that could be redirected towards hepatitis, particularly as COVID cases wane. And finally, the observed gaps in public health surveillance, which we have seen plainly observed in the COVID era, could ideally facilitate funding for infrastructure development and enhanced surveillance mechanisms, just in general for public health, which could then be leveraged for viral hepatitis elimination monitoring and surveillance in the future. Next slide. And finally, I'd just like to thank and acknowledge my collaborators as well as funders and the organizers for this session. Thank you so much for having me today.
Thank you very much, Natasha. We'll move into panel discussion. We have about a good 15 minutes to entertain some questions from the participants on the webinar. So please begin and put those forward to us through the Q&A function of the webinar. we do have one already for Don. It's about testing. You mentioned that oral fluid testing is available, has been licensed for use in Europe, but it's not licensed in the United States. The question is, do you have any sense of, is there progress toward a licensure for an oral fluid test for HCV in the US, to your knowledge?
Pre-COVID, no. There was sort of some hope for it, but it's an expensive process, so that there was very little pre-COVID. The hope is that during COVID, we could at least get some studies done as research studies to see the value of a readily administered test for monitoring HCV transmission in the community, and then make an argument for it. But we need to get that organized, really.
Mm-hmm. Thank you. Natasha mentioned home testing in one of her takeaway messages, and I've seen some data, regarding the use of dried blood spots for home testing. Obviously, that's a problem for the homeless population, but do you see that maybe having a role of improving testing access for people who inject drugs?
I think that is a possible improvement. I'm working with the CDC on a project that is trying to do very large-scale testing of people who inject drugs, working through syringe exchange programs. And one of the options is to do home finger sticks and have them brought back to a collection point, so that we probably will be testing that as an option.
Excellent, thank you. We're also joined in the discussion by Andrew Reynolds, who's the Hepatitis C Education Manager for Project Inform, part of CFAR at the University of California, San Francisco. Welcome, Andrew. Good to see you. I just wanted to expand while we're focusing on testing. It really brought to mind, what are some of the sort of the strategies that syringe service programs and other harm reduction providers are using, during the COVID-19 response to try to maintain these critical services, as Natasha so aptly pointed out. Do you have some examples or some toolkits that have been brought together to help in that regard?
Yes. I think, like Don said, a lot of places, particularly in the early days of COVID, did sort of really limit and reduce any number of services. And then I think we're kind of slowly but surely getting our feet and coming back. A lot of places are kind of coming up with new innovative ways to get syringes out into the community. You have wonderful places like Next Distro, which does mailing of harm reduction services, and they operate in a number of states. But then you also had syringe service programs, institute things like home delivery, no contact drop-offs, working with secondary exchange providers who maybe live in SRO hotels. So they get a whole bunch of syringes, they go to SROs and start to pass things out. I think, we've mentioned telemedicine as an innovative way to bring MAT. The organization I work for, the San Francisco AIDS Foundation, has done a lot of really innovative work using telemedicine for substance use treatment, which I think is really exciting and can open up opportunities for a lot of different people. And then I would just kind of push for the diagnostic side. This isn't obviously antibody testing, but it would also be really neat for us to push for a point of care RNA test, so we could really streamline the diagnosis, confirmation, and potential all in one day. And I think that could happen at community-based organizations. So, reflecting on what Natasha was saying, the Cepheid expert system, I believe, was approved for COVID relatively quickly. It works for hepatitis C. It'd be really neat if we could get them to do that here too.
Thank you. I have one other question for Don. You noticed, you pointed out the continued high prevalence of hepatitis C among people who inject drug, despite, an increase in access to harm reduction that resulted in large declines for HIV. What more is needed in New York City to really have large declines of HCV among people who inject drugs? This is sort of before, during, and after COVID. Yeah, thank you.
Yes, two things are needed. One is we need more treatment for people who are infected with HCV. That right now in New York, probably 55–60% of people who inject are viremic for hepatitis C. That's compared to maybe 2% of the PWID population who are viremic for HIV. And second, we need to do more population education. When people who inject get an HIV diagnosis, they dramatically reduce their distributive sharing. They're much less likely to pass on their needles and syringes. We don't see that yet for HCV. That there's sort of a fatalism for HCV that people who know that they're infected still pass on their used needles at an unacceptably high rate.
Thank you. I have a follow-up question. Are there currently any options to help patients experiencing homelessness since they cannot do home delivery for testing? Any other options that come to mind?
Not many. I mean, we're going, as I mentioned with the CDC project, we're going to try home testing for homeless people. I mean, it should be possible. You need a room where you could do the finger stick, and you would want to have access to running water, but it should be possible to do a finger stick. It certainly would be possible to do an oral fluid test in a homeless shelter.
Thank you. We have a comment from Lauren Sant. RNA testing would be great, but how about getting FDA to approve emergency use of rapid tests by allowing people to stick their own finger on the spot? Testing could continue with the correct PPE. So just a comment from Lauren. Thank you, Lauren. Natasha, just get you involved in this conversation. I mean, you have a lot of knowledge about a lot of different programs. So you may not want to comment on the one you highlighted, but it seemed like you were familiar with the program in Louisiana. And I was just that for their hepatitis C elimination program, was that increase in testing and treatment, which was greatly welcomed, was that joined by any improved access to harm reduction services?
Yeah, it's a great question, and we've just received funding to monitor that elimination program and do some modeling to sort of see whether it's on track to achieve elimination and really evaluate that progress as the program goes. I know that part of the strategy, although their specific elimination goals were very focused on diagnosis and treatment, the elimination program itself did explicitly incorporate a focus on expansion of harm reduction programs. And I don't actually know what has happened in the COVID era, but I think we'll look forward to monitoring that and evaluating it as we move forward. One thing that I did want to mention to kind of expand on your question to Dr. Des Jarlais about what additionally is needed to kind of address hepatitis C among people who inject drugs is that totally agree that we need more access to testing and treatment. We certainly still see here, even in San Diego, there's continued sort of stigma and lack of referral of treatments to care because of perceptions of barriers in terms of their ongoing substance use, which, as we know, is really not a barrier to successful treatment uptake and outcome. But also one of the things that we're seeing, particularly on the West Coast, is an increase in stimulant use, cocaine injection, as well as methamphetamine injection, and in particular overdose deaths associated with fentanyl that is associated with, that has been contaminated with cocaine and methamphetamine. And I think that as we see increases in stimulant use, which we know are associated with increased in risk and increased likelihood of hepatitis C transmission among people who inject drugs, it really points towards additionally looking for interventions to address stimulant use in that population. We know what to do among opioid users. We have effective medications to treat opioid use disorder, and those are fantastic and should be scaled out. But we also need a push to address interventions to prevent harm among this stimulant using population.
Thank you very much. Dave, that was a great overview about the interrelationship between liver disease and SARS-CoV-2. You brought up the cytokine storm, you brought up transplant patients, and it made me think about the role of immunosuppression in curbing that cytokine storm. And is there any benefit for the immunosuppression that transplant patients receive? Is there a subset that's at highest risk, and is some of that indeed protective? I haven't been tracking all of the copious literature around treatment of SARS-CoV-2 infection, so please give me an update on that.
Sure, and thanks for that question. It's really a smart one because, of course, as soon as the sort of parallels with the cytokine storm that occurs with CAR T cells was drawn, then every conceivable anti-inflammatory medication has been tried or is in trials to block the most logical and the sort of the first was the tocilizumab to block the IL-6 pathway, but there's also an IL-6 receptor blocker, and then there's every the inflammasome blockers exist, baricitinib, which blocks JAK1 and 2, and is a sort of rheumatoid arthritis drug, and on down. I mean, you could go take an immunology textbook out, and you'll find everything where there's an already FDA approved way of blocking it or blocking coagulation, and there's clinical trials on those. What we know right now is that tocilizumab, which blocks the IL-6 pathway, has been disappointing in clinical trials. Baricitinib has been tried in the ACT studies that are, through the Operation Warp Speed, in patients with or without remdesivir. So remdesivir was approved a couple hours ago. So that's kind of like now in as our one FDA-approved antiviral. And baricitinib, we don't have the full results of that yet, but it's probably not a big home run. It may have some benefits. So unfortunately, John, what is the truth is that we don't really understand the cytokine storm terribly well yet. And so we're throwing the kitchen sink at it, and we're not hitting very often. Mm-hmm. So I think it's going to be, I'm not, there'll be a few, obviously dexamethasone is a shotgun that broadly blocks inflammation, and that's the second, is the first to show improvements in mortality in patients that are intubated or have a lot of oxygen requirements. So that we have that as a shotgun blunt instrument to block inflammation in general, and that works. And then we have remdesivir, which abbreviates hospitalization as a direct antiviral, but doesn't appear to affect mortality. And we don't seem to have much beyond it convincingly yet.
Okay, thank you. Then one quick follow-up question is about, that association with cirrhosis and maybe some severe COVID-19, particularly advanced cirrhosis. So would you do anything different with that information? I mean, how important is it when someone gets diagnosed with a patient gets diagnosed with COVID-19 for a clinician to be assessing their liver and to be cognizant of whether they have cirrhosis? And would you do anything different in terms of monitoring and taking care of that patient?
I'll briefly speak, but we have a couple of outstanding hepatologists on the call as well, who would really be able to give a more experienced perspective. That unfortunately, there's not a lot that we can actually do differently. There's no, for example, restriction on the use of remdesivir. We first thought it was hepatotoxic, and it can be in some people, but there were in the phase 3 studies, liver enzymes went up as much in the controls as they did in the remdesivir arm. So it's not meant to be restricted even for renal failure. It just says be careful and watch what you're doing. So I think that my sense is the ASLD wants to make sure that those patients get the best possible care without regard for their liver, but obviously, really being thoughtful about the metabolism of medications and not using, especially in the child C patients. But maybe Elizabeth or Nancy would take a better crack at that one.
Mm-hmm. Nancy, do you want to comment?
Yeah, I think that some of the data has suggested that child C patients just don't do well anyway, and that it might not be that it's the COVID, it might be that it's rather the liver disease that's driving their risk of morbidity, and the infection is just what pushed them over. I mean, we see the same thing for someone who gets the flu or, comes in with a pneumonia, that patients with end-stage liver disease just don't tolerate these insults as well. Add to that the fact that they usually have sarcopenia and malnutrition and other comorbid conditions. I think it's really hard to separate out how much liver adds to the risk as compared to how much the liver is just not there to help the patient survive the insult of COVID.
Very good. Thank you.
There was a question that I suspect that Dave might also, or maybe Andrew, answer about changes in the genotype of HIV and hepatitis C. I haven't, my patients that are getting acutely infected have not been polite enough to come to clinic for me to genotype them. But I don't know if any of the rest of you have seen a shift in the population that's getting newly infected.
Oh, I get it. You mean that there would be as evidence of reinfection occurring. We have so much. We have such a dominant genotype 1 that we actually have to sequence to see reinfection. We can sometimes glaringly see it with a 3 on 1, but most of the time it's just a new viremia, not a genotype switch. So we are seeing that actually.
Yeah, same in our clinic. It's almost exclusively genotypes 1A and 1B.
Okay. Well, thank you all. Thank you.
Don?
Any other comments? Yes, go ahead, Don.
If I could make a final comment, the programs to treat and eliminate hepatitis C, particularly in people who inject drugs, are almost exclusively government funded. And COVID is causing a real crisis with government funding at the state and local level. I know of syringe exchange programs that are just running out of syringes because they're not getting their budgets paid and can't go out and purchase syringes. And, within the political environment, dealing with hepatitis C is going to be a lower priority compared to laying off teachers, laying off hospital workers, laying off reducing mass transit, and all of the other potential state and local budget problems. So that those of us interested in eliminating hepatitis C are going to need to be ready to take action to support the funding of the efforts.
Absolutely. It's a good call to action. Absolutely. And I think that's one of the data coming from Natasha is really important to help us reveal what are the consequences of those. And we really all have to continue to work together across clinical, community, industry, government to bring these issues to light and really get the services in place to continue our progress toward elimination. Thank you very much. Thank you all presenters for a great webinar. Thanks to the participants. Again, this will be on the ASLD website for later viewing, and please keep in touch. Thank you all and have a good evening.
Thanks, John.
Thanks, John.
Thank you. Thank you.